Welcome to this presentation for internationally educated midwives who might be new to the UK or are hoping to come and work here. This is specifically designed to try and simplify the journey a pregnant couple go on from conception all the way through to having their baby. As always, please do take a look at the references at the end, as it will be very useful for you to read about the antenatal pathway and the standard NHS screening in particular. So our learning objectives for this session are for you to come away with an understanding of all the points of contact a pregnant couple can expect, and to gain a high overview of what happens within each and every midwife-led appointment. As such, it is hoped that you'll gain a feel for what the midwife's role is throughout the whole journey, what tasks need completing, your responsibilities and extra considerations that might be needed. And very probably this will prompt some further reading for you on anything that I mention which sounds completely unfamiliar. I don't wish to teach you things that you feel you already know well. However, there might be very subtle additions or changes in timings to your previous practice knowledge of antenatal care. So I'll try and be as thorough as I can and keep it to a high level overview at the same time so you can spot any differences to antenatal care from your previous experience. So let's take a quick look at the journey of appointments a pregnant person will be required to attend. As I say, I've kept this to a minimum, so following the pathway that a completely low-risk pregnancy would take. And so please do bear in mind that when a consultant referral is required, those who are then on a consultant pathway or seeing any other specialist, they will probably be seen slightly more often. However, on both the low-risk and the higher-risk pathways, it's important that the midwife remains checking in regularly throughout. With that said then, we've got a booking appointment as the first usual point of contact, and we aim to have this completed well before 12 weeks, ideally on or before the 8-week mark of pregnancy, if not earlier. We refer from there for a dating scan. And based on the estimated due date from booking, we want this to roughly land around the 12-week mark for completion of some screening, which I'll talk about in a second. The first midwife review then is well into the second trimester at 16 weeks. And a low-risk pregnancy is usually only offered 2 ultrasound scans throughout the whole pregnancy, so the second being around 20 weeks, which is the more detailed anatomy scan. Following on from that, we tend to see women having their first baby slightly more often, so we'll fit in another second trimester review for them around 25 weeks. Then from 28 weeks onwards, we start to review all pregnancies more often, keeping track of the baby's growth, fetal movements, mum's well-being at regular intervals. For lots of hospitals following GROW pathways, it is recommended fundal height should be measured every 2 to 3 weeks, and this is what we can see as we move forwards, with a review planned every 3 weeks or so 31 to 34 there. Around 36 weeks, it's good to also ensure that all birth and preparation conversations have been had, ideally all the way along, but to make sure that in case labour happens, the parents know exactly what's going to happen from 36 weeks. And then towards the end of pregnancy, we might start seeing somebody almost weekly for a review. We have the option of cervical membrane sweeps before a possible induction of labour, before labour and birth. So I want to briefly explain what will happen at every stage of the journey I've just described. The booking appointment is usually the first point of contact with a midwife. As soon as a woman has taken a positive pregnancy, she is able to make a referral to her hospital of choice. This can often be done online these days, so finding the hospital that they would like to book at and sending off their details. The general practitioner at their GP surgery can also help in sending a referral of pregnancy to the hospital. At this first appointment, so let's say 6 to 8 weeks, we're in need of a full history of the person presenting for care, to include medical, obstetric, family, social, mental health histories. We're also going to offer the ladies some standard investigations and screening, including blood tests, urinalysis, carbon dioxide testing, a BMI calculation, plus the ultrasound scans that I've mentioned. The appointment will also include a large quantity of health promotion topics, and I'll briefly touch on those. So I just want to interject here with a separate screening timeline of the whole antenatal journey, please do, if you haven't already done so, familiarise yourself with the screening tests for you and your baby information, which just helps to map out the timings of all the screening that is offered to mum and baby. These are all the bits that we screen for antenatally. So just to read through this list from booking, we take bloods, which include infectious screening, so that's HIV, syphilis and Hep B. We take a full hemoglobinopathy screen, which is testing for sickle cell anemia and thalassemia. We also want to take a full blood count, which will include an iron count and platelets. We take a random blood glucose measurement for diabetes from booking, and also a group and save, so blood group and antibodies. A midstream urine sample is taken at booking, so sent off to the laboratory at booking for any underlying infections in the urine. And we've got 12 weeks ultrasound scan, and although the sonographer is the one undertaking the scan itself, the midwife at booking is responsible for consenting to it and explaining it. Now, we're testing for Down syndrome primarily, but also Edwards and Patau's syndrome, which are all genetic chromosomal syndromes. It's a combined screening test of taking a neck measurement on the ultrasound, plus a blood test from mum, and combined with her age, it gives us a risk factor result. So she might be high risk or low risk for her baby being affected. Next bullet point down, some hospitals also offer routine testing for rhesus negative ladies at 16 weeks-ish to find out if baby is also rhesus negative. This can prevent us giving unnecessary anti-D products, which is a blood product. Obviously, if baby is rhesus positive, that's opposite to mum, then mum does require anti-D later on. Okay, next on our screening, we've got the 20-week ultrasound scan. We might hear this called an anomaly scan, where again we screen, and it's specifically 11 conditions that the sonographer is checking for. And lastly, at 28 weeks, those at risk of diabetes are required to take a glucose tolerance test, whilst all pregnancies should have repeat bloods tested for antibodies and iron levels. That is all the routine screening, and obviously if the doctors deem necessary, there are extra tests that can be done. This slide contains absolutely everything that a booking entails. It's a huge gathering of health and social histories, risk assessment and referral assessments. I'm not going to go into each and every element, but feel free to pause and have a read through this list. If you get a chance to observe some antenatal bookings as soon as possible, this will hopefully not be such a scary list, but more of a checklist that you're able to go through in correct order of your hospital notes. Now, the appointment does also include health promotion topics on a lot of advice, such as taking folic acid and pregnancy vitamins, a woman's diet and nutrition and food hygiene, lifestyle factors such as drinking, smoking and drug use. We should also advise on vaccinations in pregnancy, including flu, whooping cough and COVID vaccinations. We can discuss legal rights once pregnant, which includes access to maternity exemption of prescriptions, meaning they don't have to pay for any prescriptions, and statutory maternity pay organised with a MAT-B1 form, which they hand to their employer to be able to have maternity pay from their employer. So the second point of contact with a midwife will be around 16 weeks, now perhaps at a GP surgery or another antenatal clinic location. Let's take a look here at what the appointment entails from you as the midwife. Every time we see a woman, we want to make sure every contact counts, and that includes being kind, caring and good listeners, which in turn will help your women to feel cared for and safe. So at the start of every appointment, we should kick off with an introduction and ask about the woman's well-being, physically, emotionally, building a rapport and trying to listen to any questions that the woman arrives with. By 16 weeks, we should have already checked all results, so everything taken from booking plus her first ultrasound scan screening result. We need to check that this has been recorded in her personal notes and inform her of the results if she hasn't already been told of them. We can check the care plan ahead is all in place, whether she's been given her next 20-week scan appointment, for example. We can also remind her about vaccinations that are offered so that she can receive those in good time. Now we have several other tasks to complete at every single appointment, including taking a blood pressure reading and performing urinalysis, as well as reviewing any recent results. We can consider possibly she needs iron supplementation if her iron was low at booking. If any referrals that we spot were missing from booking, we can make those extra referrals. Again, some hospitals around 16 weeks also offer the cell-free fetal DNA testing for women that are rhesus negative in order to decide if she should later receive anti-D injections. And lastly, at every appointment, we have the definitive responsibilities of clear documentation and the thorough checking of the woman's care plan. So that's a rough overview of 16 weeks. Let's move on to the 25-week review, generally reserved just for the first-time parents-to-be. Again, we want to be kind, caring and good listeners. So at the start, we'll introduce ourselves and ask about her well-being, continuing to build that rapport with the woman. Now we can have extra conversations here, such as discussing repeat blood tests that she'll need at 28 weeks to recheck her antibodies and iron levels. We might check if she's already booked any antenatal classes. We can discuss bonding with the baby, whether she's feeling any baby movements and what's normal when she should be concerned in terms of movements. We can also offer the MAT-B1 form from 20 weeks by known due date. Again, our tasks here are to complete blood pressure reading, performing urinalysis, as well as reviewing any recent results. This time, though, the woman may be keen to hear the baby's heartbeat through an ultrasound Doppler. Now, this is not part of NICE guidance recommendations, i.e. it's not actually necessary if the woman is happy with her fetal movements. However, many women request this, and it can be a lovely thing for the women to hear their baby's heartbeat in clinic. We need to make really clear, however, that it's not safe for them to do this at home with their own Doppler, as they're not trained to use it, and that even for midwives, it only provides a snapshot of the fetal heart activity, so it's not for use in terms of reassuring us of baby's well-being. We will rely on the baby's movements instead. Again, our responsibility at 25 weeks is to complete our clear documentation and thoroughly check her care plan. Now we're on to the 28-week review, and we're going to see all our women at this point, so multips and primips. We can have extra conversations such as fetal movements and when to call hospital to get checked over if they are concerned about lack of movements or a change in baby's movements. That is the best way that mum knows that her baby's okay. So we need to also make sure that pregnant couple have started to have conversations around the birth and start answering any questions for them, including breastfeeding conversations. As well as all our previous tasks to complete once again, from 28 weeks, we're going to offer to measure the baby's growth for the first time with a fundal height tape measurement. This is then plotted against the local hospital's personalised growth chart, which keeps track from here of the baby's growth. Now, alongside documentation and checking of the care plan, we have the responsibility to refer for a growth scan if we have any concerns about the size of the baby, as well as any other deviations from normal that are worrying us. Now, if you're ever in doubt, ask a colleague or refer. Don't leave something that you're not sure about to go unchecked. Moving on. Oh, sorry, that's just a picture of a sample growth chart where we've plotted from 28 weeks onwards the baby's fundal height measurements. So moving on to 31 and 34 weeks, roughly our next two appointments. So our additional conversations are possibly slightly repetitive now, but we want to be thorough in checking all the bits we have done so previously. So we'll likely continue our conversations around birth. Again, in our list of tasks here, we're going to offer to measure the baby's growth with a fundal height tape measurement. We'll plot this on the personalised growth chart to keep track and check there's no excessive growth, any static growth or tailing growth. All of those may be of concern and we might refer for a growth scan. We want to start gaining more of an idea of the baby's position in the third trimester through our abdominal palpation. And again, we have a responsibility to refer if we've got any concerns at all. We're getting there, guys. We're on to the 36-week appointment. Stay with me. In our extra conversations, we want to be thorough in checking all the bits we have previously, as well as making sure we've done all we can to prepare these parents-to-be for their baby's arrival. So we will likely continue our conversations around birth, making sure that by the end of this appointment, they've discussed all of the possible outcomes of birth, as well as the signs and symptoms of labour, when to attend hospital, caring for the baby when it's here, and what to expect in terms of appointments for baby. And then we'll also discuss vitamin K and newborn screening that happens straight after birth. It is crucial that we try our best to ascertain baby's position by 36 weeks, because if we believe the baby to be breech or indeed any other position other than head down or cephalic, we don't have a lot of time to encourage baby to move around, as the rate of growth is so fast by now. So usually an external cephalic version is offered to help turn baby anywhere around the 36-week mark. And so if you're not sure that baby is head down, we need to get a presentation scan to confirm baby's position at 36 weeks. Now, our parents-to-be should leave this appointment feeling completely equipped for birth and having had all their questions answered, so they know who to call and when if they think that they might be in labour in the weeks to come. Right, so 38 weeks. Again, we want to recap the appointments discussion, exactly when and why to call the hospital in terms of signs and symptoms of labour. We might also need to start discussions around induction of labour, which is most routinely recommended at 41 weeks. Now, most people will have wanted to completely avoid the possibility of an induction. However, we need to stress, particularly for first-time mothers, that it's very, very normal to be overdue. They will want to know all the details of your local policy on induction, what methods are offered, how they work, whether they will be allowed home while waiting for things to start, etc. The priority remains giving these women as much information as possible for them to feel able to make the best informed decisions for their own care. Now, you as the midwife are usually the person responsible in making sure that an induction is booked and explaining to the women how this might happen. We might see primiparous women again in 2 weeks' time at maybe 40 weeks. Multiparous women may wish to be seen later, although both groups may wish to try cervical membrane sweeps from 40 weeks to try and get labour going. Once more, we're going to check the baby's position, and we can also check the engagement of the presenting part within the pelvis. So at 41 weeks, we're often at the point of routine induction for post dates. However, if women decline at this stage and choose to wait a little longer, they may need a review and a personalised care plan at this stage made by a doctor. At 42 weeks, even if the woman's declined at 41 weeks, we're probably at the point of having an induction of labour for post-term dates. This in itself may become an increasing risk to the outcome of pregnancy, i.e. being overdue. And if the lady is reluctant to have an induction at this stage, there's normally a conversation around the increased risks associated with placental function. And between 41 and 42 even, we may have had regular CTG monitoring organised. If a woman is completely set against an induction and just doesn't want to have one, a consultant usually needs to have a conversation here about the options moving forwards, which includes an offer of elective caesarean section to expedite the delivery and minimise the continued risk. Phew, we've made it to the end of pregnancy. Now we have labour and birth. Baby is born. So the woman attends hospital to have her baby, or she may even have it at home. And then we commence postnatal care, and we're going to do a separate presentation to outline the ongoing journey that the woman and baby will go on from here. In hospital, though, right after birth, we're going to initiate a feeding plan and make sure that we're happy that baby is being fed from birth, but especially before we discharge mum and baby home. Usually in hospital as well, though, before they are sent home, we complete the newborn checks, which includes the NIPE and baby's hearing screening. These are the resources used for today's presentation. Please do read the screening tests in pregnancy and the NICE overview of antenatal care, which kind of covers everything in a little bit more detail. And please do leave us some feedback from this presentation. Follow the QR code here or the link below the video. And please let us know if you enjoyed this presentation or if there's anything we could improve on. Thanks for watching. We'll see you next time.